at night, I don't. And this is all that's changed. So I don't know if it's something to do with tubes and stretching me out, what it is.
Okay, and what about tingling fingertips?
No.
None anymore? Fantastic. Okay, so all in all, apart from a pretty smile, you feel a lot better.
I feel a lot better, a lot more confident. Yeah, the whole thing is amazing.
Yes.
Really nice.
Good. Excellent.
Okay, so that was as a result. We did nothing else but build her teeth up. And I'll show you what her bite was before. So when you look at that, you see the supereruption of the upper jaw, because she had such a class 2 div 2 that the teeth completely missed each other. And why in someone who has a bite like that are all her front teeth so worn? They don't even meet in her bite. Because she used to posture herself forward all the time. She used to grind forward. Her body knows that her jaw needs to come forward. So at night when she sleeps, she grinds forward. She's got this bicuspid drop-off. She has supereruption of her anteriors. So this was the new bite. So from her original bite, like that, her new bite whacks up. And look at her before. She used to have a tongue in there as an orthotic, just prying her jaws open, trying to keep her jaws open. And this is the after. And a change in her face and her profile. And all this without surgery. So when I rebuild smiles, I don't only want to rebuild the look. I want lasting aesthetics. I want stability. I want comfort for them, form and function, and physiologic balance. Isn't that what we all want for our patients? So it comes down, we start with diagnosis. So what do you think that is? When you see something like that, is it toothbrush abrasion? No. Okay, you can't just brush one tooth, can you? What about that? This lady came in today, in fact, and she said that her dentist told her that she was brushing her teeth too hard. But I beg to differ. What do you think that's from? Yeah? From grinding and clenching, maybe? And flexion and abfractions? What about this? We see all this, you know, the enamel's chipped off the front, off the sides. And this? These are the typical patients I see almost on a daily basis. And, you know, traditionally what we would do is, okay, they want a nice smile, they want to replace the teeth, you go ahead and do that. But they're still in the same place. They have to wear a splint every day because they'll break everything again. Yeah? Well, the treatment that I've learned is to actually give them a bite so they don't do that anymore. They don't grind anymore. We can rebuild the whole mouth in full porcelain and they'll never break anything anymore. Okay, so that's what I'm sharing with you today. So even someone who looks like they have the perfect bite doesn't mean that it fits in their body perfectly. This young patient who had ortho had a beautiful bite, beautiful smile, but he had unbelievable TM joint damage. Really a lot of pain, a lot of suffering. So it made me rethink now what are we doing for our patients? When is it appropriate to alter the existing bite? You know, say in a patient like this. This was one of my first cases, in fact. He came in, he wanted a new smile. I said, yeah, I can do a new smile. We just, you know, do some crown lengthening and, you know, put some veneers on. Yeah, no worries, we'll do a new smile. But you've got to wear your splint every day because we're not changing your bite. He didn't wear his splint every day. He didn't wear it, in fact, at all. And I got an abusive letter from him saying, the work you did is crap because it's all broken. I've gone to Thailand and had it done now. But, you know, I said, you have to wear your splint because I'm not changing your bite. So do we want that? I don't want that. You know, some patients, I mean, yes, we don't want to change the bite on every patient, you know, and there are compromises as long as they understand that that's what they've got to do. But that, you know, you don't want to own cases like that. So even though you can get a really nice aesthetic result, that's not all, okay? So change only occurs when one is no longer satisfied with the status quo and realizes that the things that we were taught were not working. Okay, I learnt my lesson with that one, and many others. So I had a lot of burning questions when I come in with, when I get patients with a lot of complex problems. You know, when is masticatory dysfunction an occlusion issue? When are joint derangement issues caused by occlusion? When are masticatory pain issues teeth issues? When someone has limited opening but no pain, do we just ignore that? Or clicks in jaw joints that don't hurt, which a lot of them don't? Chronic bruxism, is there any other treatment other than Band-Aid treatments that don't actually stop them grinding? They still continue to grind. What about Tmj symptoms? Why do some suffer incredible pain issues and others not? Is there a way that we can help cure these issues rather than just a Band-Aid, like Botox or splints that don't stop them grinding? Or drugging our patients with Lyrica, diazepam, endone, Endep, and sending them to psychiatrists when there's nothing else we can do, saying that it's all in your head, you're making it up because of your stress? That's not acceptable to me. I mean, sure they are, sometimes they are disturbed people, because is it the pain that's causing the distress and the depression, or is it the depression that's causing the pain? Who knows? Is there a way we can break the cycle of pain and destruction and have long-term permanent results for our patients instead? So what is occlusion in the sense? It's in the dental context, it simply means contact between the teeth. In relationship between the maxillary and the mandibular teeth where they approach each other as occurs in chewing or at rest. That's the Wikipedia. Malocclusion is the misalignment of teeth and jaws, and more simply, a bad bite. And it can cause a number of health and dental problems. But what it really is a dynamic phenomenon that includes the afferent proprioceptive and sensory input affecting the central nervous system, mechanisms, and resultant state of muscle tonicity. So it goes beyond the understanding of cusp and fossa relationships. It is the vertical endpoint of a dynamic activity that involves the mandible, the maxilla, dentition, TMJs, the masticatory muscle systems, neighboring craniocervical muscle systems, as well as the peripheral and central nervous systems, the neuromuscular skeletal system. Okay, and we can't escape it. It's a fundamental element in dentistry that almost all departments of dentistry, pros, restorative, oral, you know, you name it, we have to deal with it. We can't ignore it. And as dentists, we were not traditionally trained to think that the masticatory system as a many dynamic functioning entities working together in a relationship with one another. We think about teeth mainly. There's a physiologic relationship between the joints, the muscles, and the teeth, and the CNS. When those oops, go back. Sorry. Okay. It's a combination of many factors that bring these parts in relate and bring the body into alignment, health, and function. Teeth dominate, joints accommodate, muscles accommodate. Does that make sense to everyone? Yeah? So where our teeth fit, that's where our joints and our muscles just have to go. Okay? So it's an intricate balance between the three, but really the teeth and where they end up and where we bite actually controls the other two. And the human body, it has a great capability to adapt